Welcome to Talking Science Africa, a show where we bring you researchers and experts in the field to discuss the work they do and explain it to us in a layman's language that we can understand and take actions that we should take in supporting science and implementing their work. Today we are pleased to host Emeritus Professor David Serwadda. He's a Professor of Public Health at Makerere University. And he is a unique researcher in the sense that he has been studying one of the most common diseases in Africa. We could call it the most devastating disease in Africa that has killed millions of people, that also continues to kill millions of people, and that is HIV/AIDS. Professor Serwadda started researching on this subject in 1983, and he co-published the first paper on this subject in 1985. It was the first paper in Uganda that helped us to understand the disease, and since that time he has been publishing and helping us to understand the disease. Professor, welcome to the show.
Thank you for having me, Mr. Msenguzi.
It's a pleasure. Yes. So, early 1980s. You were a young researcher.
That's correct.
At that point in time.
Yes.
What made you pick interest in this strange illness that was killing people in Rakai?
Right. So I was indeed a young researcher. So when I had just finished my internship in Zambia in 1983, I was posted to Uganda Cancer Institute here in Kampala, in Mulago. And remember, when I was in medical school, I actually spent a year as rotating through Uganda Cancer Institute. And Uganda Cancer Institute, therefore, when I finished my internship, they requested me, the leadership requested me to return to Cancer Institute. So I was in Cancer Institute. So Cancer Institute holds a journal club. In the journal club, we review articles specifically related to cancers, the cancers we specifically are interested in. So Uganda Cancer Institute had two sides. It had the section on lymphomas. Those are mainly tumors or cancers that affect the lymphatic system. And then there were a section called the solid tumors. These are tumors that are solid tumors. And on that section, we had been traditionally treating Kaposi sarcoma. Kaposi sarcoma had been an endemic tumor in Uganda for many years. But what happened is during these journal clubs, and I'm now talking about 1983-84, we increasingly saw more reporting in the New England Journal and the Lancet of an epidemic of Kaposi sarcoma in white young males in North America. And this was a very rare tumor in that part of the world. That's how the connection came about. So why were they having this tumor? And then eventually it turned out that these people were actually having what a clinical symptom referred to acquired immunodeficiency syndrome, AIDS. And increasingly people who had this picture were actually coming down with this tumor. So we said, but we also have people with Kaposi sarcoma. Then it became clear when we were reviewing these journals that the presentation of this Kaposi sarcoma was different from the one we had. The tumor of the cases we used to have in Uganda, they affected the limbs, and the upper limbs and the lower limbs. But these tumors of Kaposi sarcoma could be found in the lips, in the face, and on the trunk. So this was a different presentation in terms of sight. And we used to see our tumors as small nodules, but these were like skin plaques, so it was different. But, so we said, okay, this is somewhat different, but behold, we started seeing in our cancer institute patients coming up with this picture that were being described up in North America. And I remember distinctly seeing 4 cases. In fact, we published those cases. Those, to be honest, were the first cases, but we published them in the journal British Cancer. But it came out much later than our papers that we published in Lancet. But when we saw those cases, it's interesting they were all coming from Rakai. And the other thing was, your viewers need to note that the Kaposi sarcoma we used to see in Uganda for years were mainly predominantly a male disease, a male problem. And yet the cases they were seeing, the cases we saw in Uganda, those particular 4 cases that were appearing with a typical presentation, 2 of them were females. Female Kaposi sarcoma in female was very rare at that point in Uganda. Now remember, Mr. Musenguzi, at that time, we didn't know what is the cause of AIDS. There was a lot of speculation of what will be the cause of AIDS. So it was only in around 1984, the spring, April in 1984, that I was reading a Newsweek article where they reported that Dr. Gallo, who was then the director of the National Cancer Institute in the United States, in NIH, reported that he had been able to find the cause. It was a virus. It was referred to at the time as HTLV3, which we now know as HIV. And soon after, tests became available. So we were very excited. So what happened is that we decided to take blood of these cases, of all our Kaposi sarcoma cases. In Uganda Virus Institute, taking off blood for storage was routinely done. It was a routine practice. But I was helped by a gentleman called, a surgeon, there was a British surgeon called Wilson Caswell, who helped us to take these bloods out to be examined for. At that time we couldn't be able to to examine for HIV, but there was a colleague called Robert Downing in Porton Down in UK, whom we sent these blood tests to actually examine them for a virus. Then I remember after some time I get this aerogram. Many of your viewers may not know what an aerogram is.
Even I don't know.
An aerogram was a blue. It was a blue sheet that had already a stamp on it. So you write on it, and then you fold, and then you mail. It has already. So I got this aerogram from Robert Downing, saying that 4 cases of the blood samples I've taken were positive. Those were the first actually identifiable cases of HIV in Uganda from Cancer Institute. But all these 4 had come from Rakai. That was the first connection. And that actually prompted us in January of 1985 to launch an investigation on what is really going on in Rakai. Now, a couple of people of us actually went down and examined people in Masaka, in Kitovu, and in Kalisizo Health Center.
So where did you find money to go and examine people?
We were just using our own money. In fact, the blood samples we got from there, they were put in my own fridge for storage. We were just using, it was purely driven by curiosity. So we were just being driven by curiosity. And when we got to Rakai, there was a medical officer called Dr. Luegaba in Kalisizo Health Center, who actually told us he had already written a report to the Ministry of Health about a strange disease that is killing people in Rakai. people just come, they got skin lesions, and then they have chronic diarrhea, they waste away. In fact, the people in Rakai had called it slim. People slim away, and they die. We did not know at that point until we got there. So when we examined people on the ward, took off samples, took off stool, took off sputum, to try to evaluate whether this is an epidemic of TB, this is what is going on. We then take these blood samples again to our friend in Robert Downing, and behold, quite a number of them were positive for HIV. And what struck us was there were a lot of people who were on the ward who had what we thought was malaria or other unhealthy problems. They turned out positive. That was the first time we said, hey, people can look relatively not wasted, with completely emaciated, and they have this disease. The findings of that report of our expedition in January 1985 were put together, and that is what came out as in the Lancet paper, the slim disease. But it was completely, we paid for our own petrol, we went and paid for our own hotel rooms, and that's how this came. That is how we get a wind of this. Yeah. Now remember, at the time, you also need to look at the context. At the time, Uganda was more or less having an internal, we were having a civil war within Uganda at the time. And, there was a huge rebellion going on in Ruelo. The ministry actually had initially sent its own group to investigate, and they said this was an epidemic of typhoid. And the other context is that we as researchers were having a lot of headwinds. At the time, reporting that you have HIV in your country, people were being embargoed to travel for work, for study, if you were HIV positive. And countries were shining, tourists were shining countries that were reporting cases of HIV. Now, to come up and say Uganda has these cases are HIV positive, we had a lot of blowback. How did you find out this? How did you? It wasn't something that government was very excited of the day to hear. That was during Obote time. And therefore, this information was taken coolly with a lot of
skepticism. Yes.
And we also laid low. We never really publicized it, or had talk shows or people bringing us to go. I had lots of invitations to go to talk about this problem, which I could not, because at the time I would be as if I am in a loud mouth for this problem in the country. Yet, the country wasn't that very keen to advertise it during Obote II government.
Thank you. So, the other intriguing question for me is, why Rakai? Why did these cases concentrate in Rakai, not in other parts of Uganda?
Mr. Musengus, that's a very good question. But it increasingly became clear that when we talk to people in Rakai and you trace backwards, who are the first people who came down with this disease? It seems like the first people who came down with this disease were traders, who were actually traders concentrated around Kasensel, which is a landing site on Lake Victoria in Rakai District. But they were mainly trading between Uganda and Tanzania. And it is interesting, in those early days, I'm talking about the mid 80s to mid-90s, actually the Kagera region in Tanzania also had the highest prevalence of HIV within the whole country. And we in Chotela had very high prevalence of HIV in Rakai. It seems to us that HIV transmission was going on in those areas for a very long time, but very slowly. But we would like to link the fact that in 1977, 78, 79, Idi Amin annexed Kagera. Lots of soldiers moved into Kagera and completely annexed it. And the people there left, you know. He moved a whole, we were on TV, we were seeing battalions of people moving there. And then what happened is that Nyerere, who was the president of Tanzania at that time, decided to mount a counteroffensive. So there was to push soldiers out of Tanzania, Kagera region. But then decided that it would not be good enough. He wanted to push them all the way, completely, what you would call regime change. So there was a lot of civil unrest. And we do know that actually when you look at other countries that had civil unrests, actually the epidemic of HIV came up. Civil unrest, we would like to think, displaces people, displaced camps that have very high HIV prevalences, we know that. And there's a lot of sexual activities. And so I think that stirred up, in common language, stirred up and increased the spread or the rate at which the HIV was spreading to the rest of the country, and both ways in Tanzania and in Uganda. That's what those two timing makes that explanation fairly possible.
So we are not certain about when Uganda had the first case of this disease.
It's very possible that Uganda, before we reported, transmission of HIV in Uganda was already taking place. Very highly probable. But at a very slow rate.
At a very slow rate. So what's the origin of this disease? Has it been identified? Where did it start from actually?
I think we now have a fair understanding that HIV, there is a very similar virus called simian immunodeficiency virus in monkeys, and we think it is a species, jumping of species. We think that this virus was originally in primates, but because of the way some groups interacted, particularly in Central Africa, interacted with, some people hunt monkeys, they eat monkeys, there could be spill of blood, and if you have cats, it could create transmission. There was a species jumping from simian HIV into human, and then over time, this changed into what we call now HIV. I think that relationship is increasingly becoming very clear, and most likely this is a disease that has been a long time been around, but the transmission has been very slow and in isolated population. But with urbanization, travel, with the fire of civil unrest, it flared up the rate at which transmits and the rate at which it spreads. That is more or less the picture that we are now coming up with.
So let's go back to Rakai, 1984, 85, 86 and onwards.
Right.
After discovering these illnesses and going to communities,
right,
spending there a lot of times.
Sure.
What were the perceptions of people about this disease? How did they respond to it?
Mr. Msinguzi, I started going to Rakai in 1984, and I've been going there since. I've spent over 40 years going to Rakai. Remember, if I move fast forward, we established a population-based research program in Rakai. So we have a program there called Rakai Health Science Program that has been going on there. But in the period that you're referring to, Mr. Msinguzi, HIV devastated Rakai. People watched men slimming away and dying, then their families slimming away and dying, and you'd go into households. You know, you're going to a household, in the front yard there are graves, the husband, the wife, and I remember very vividly when we were doing some surveys in 1990. Before you do a survey, you do a census. And I remember going to a household with my colleagues, and it looked abandoned. And then we yelled out for anybody here, and then a 9-year-old boy came out with torn clothes, and then I said, "Where are your parents?" They said, "They are not here." And then 2 other boys came out, in fact another boy and a girl. I think it may have been like 7 and 8, and they said, where's everybody? They said, "Mom died, Dad." So who is the head? Because we always census, we looked at the head of it, we interviewed the head of the household. So they're the only one. In fact, these were childhood-headed households, and this was not unusual. So what happened is that quite a lot of people died. Some of the kids could be taken away, absorbed by other relatives, but some relatives were already gone. So they were just more or less, on their own. So that period really is where you really see a very disturbing social manifestation of the impact of HIV. I would call it very high mortality, meaning that the disease to start, because of the way we know the natural history, meaning that by the time you start having people dying, we know you get HIV. By the time you start to get symptoms, it takes about 10 years, naturally. 10 years to start getting symptoms of HIV, then you get symptoms, then you start to get, that is now the opportunistic infections comes in, that's when you get the symptoms, and then it could take you anywhere between 1 to 3 years to die. So, but that means that these people were infected a long time ago. And so that was the picture, a picture of high mortality in the population. So people knew once you started to slim away, death is going to visit you soon. And so people were very worried about it. And that's why you found that even people who had been from Rakai, gone to town, and then they start getting these symptoms, they left Kampala and then went back to the rural areas. So it was a very gloomy picture. We did not know what to do, how to treat it. We just were treating what you call medically symptomatic. People had, fungal infections in the mouth, fungal infections of their gastrointestinal symptoms. They would have these skin cancers. They would have infection of their brain by a fungus called Cryptococcus. It was very miserable, very miserable. So at the time when we started work in Rakai, because of what we saw, when we first wrote the first paper, we decided that we need to know more on the dynamics of HIV transmission in Rakai. Who, where, and why people infected, and in the hope that this will give us answers on how we can do interventions. And I remember our first grant came from USAID. Mr. Msinguzi, through Columbia University, is the one that actually started us off at the time to get to understand the epidemiology of HIV transmission. But it was that period was very dire in terms of, if you went into the natural geographical magazines of that time, if you looked at lots of journalists writing at that time, it was devastating. But I can tell you the weekly journal, there was a weekly newspaper called the Weekly Topic. I think the Weekly Topic does have a very good article around that time of really what was going on in Rakai. That is something that was very, very disturbing. But remember, the government of the day at the time was more focused on fighting a civil war and survival, and not very keen to actually advertise that HIV was in its boundaries. So that actually lost us time to really do intervention. The real government that took HIV seriously was when Museveni came in. Now Museveni comes in 1986, and thereafter that was a huge change in terms of how we approached HIV, both as a government, the leadership that is required to manage it.
Back to the communities in Rakai. So what beliefs did they have about the causes of this disease?
Typical African approach, bewitched. In fact, there was a tree planting program that was actually going on in Rakai and Masaka by I think the Norwegian government. They created nurseries. There were several nurseries. I actually bought a lot of avocados for my own home to plant, but there were certain trees. Now people felt that when you bought that tree and you put it in your garden, you're gonna die of HIV. It was people who, you see, the early days, the people who were getting down with HIV were mainly traders, people who had a bit of money. And therefore they had a nice house, they were trading in this, they were moving around, they would buy some of these trees as they built their houses, and then they would die. So witchcraft was one. Mainly, it was witchcraft. It was mainly the issue that was pushed, in Rakai.
Yeah, you have some man and then someone has bewitched you.
It's a very common problem, very common concept in terms of people how they relate to death and causation. So that was very high, actually. Moving on. People did not take this as a sexually transmitted disease or something related to sexual transmission. It was mainly people thought they were being bewitched at all. Yeah. It never occurred to them that, but the kids are there. But the main thread was people get bewitched.
Where we are today,
yes.
40 years of understanding this disease.
Yes.
Why is it that we still have actually these beliefs of someone has bewitched me, a pastor can cure HIV/AIDS, a traditional healer can cure HIV/AIDS? We had a recent documentary in Kenya where a pastor in Nairobi was claiming to have cured people of HIV/AIDS, and they had fake documents. So the journalists went to investigate, and of course the journalists could not find evidence. Why is it that we still have these beliefs, even among the elites, educated people?
To be sure, in our desperation, now I'm talking about the 80s, the 90s, and the early 2000s, there wasn't anything really tangible. People were so soiled that it would prevent you. The priests were also preaching. The traditional had all kinds of things in desperation. But at this point in time in Rakai, which I know best, I don't think people are now thinking that they can go to a priest and the knowledge and the fact that antiretroviruses have really been a game changer. In Rakai, anybody who had HIV positive and wanted to be on treatment got on treatment. The people in Rakai have seen people rise from their deathbeds through treatment and actually start to walk and then start to dig.
It was some sort of a miracle.
Even I myself, I was equally surprised, to be honest. I do not see or hear of preachers that can treat as a way of pulling people, because they have seen what this medication can truly do. That you cannot, I think, convince people that something else is going to help them while they have seen this has helped them. People in Rakai are extremely grateful for, they have seen, because the death rates were so high. Now it's almost gone with these drugs. A preacher can't come and tell them that now this can treat you when I'm already seeing what I am, So I have a feeling that but Dr. Mr. Msi, have you seen those in Uganda, preachers who are treating?
Yes, we have them.
We do have?
Yes.
Oh. And people go for them? Maybe when the drugs become scarce. But I must confess that it is not something we have experienced in Rakai. I don't hear it at all much. It's possible. It's my lack of knowledge. But if it was a big thing, we would have heard about it, at least through our studies.
Again, you have talked about the people. The problem. Yeah.
The problem that might be in Rakai, maybe elsewhere, are people who have been on treatment and they got better. Okay. And somebody tried to convince them, and this is common also in people who have hypertension or diabetes or all these chronic diseases, that no, you can we can pray for you and we get cured. You don't need to be on drugs. I've seen that in people with hypertension, people with diabetes, only to come back worse. In other words, move them from whatever they were taking, thinking that this will actually cure them. Because we are telling them, we are not curing you, we are just suppressing the multiplication of the virus for you to get better, but it's not a cure. We tell them that. Somebody else can say, no. For us, we have a real cure. You don't even need to take those drugs. So I've seen that not only in HIV, but also in hypertension. I've seen it in people with diabetes, or even people who have cancer. Says, no, let's come and pray for you. Don't bother with this. Don't bother with this medication. So that I consider is fairly prevalent in Uganda among all kinds of diseases. So maybe I may consider that point in that way.
When did we have HIV/AIDS medication, and what was it like for people infected with HIV/AIDS before this disease was available? What kind of treatments were they being given?
I can tell you exactly where I was the conference, the AIDS conference in Vancouver in 1996, I remember saying, oh, this conference, I've really spent it all my time in Vancouver in the conference rooms, not going out, sightseeing. In that conference in 1996, that's when a lot of evidence and data was produced, where we what we call triple therapy and its impact on the trajectory of HIV. Triple therapy was basically using 3 drugs to actually treat people. And at that time, the concept of viral load had also become very well known. A gentleman called David had already also figured out how viral loads are related to disease progression. And therefore, high viral loads, you go down very fast. But these medications, the triple therapy, clinical trials, so they were reporting on the results of clinical trial, reduced viral load, reduced the progression of HIV. That was the first time we really knew that medication is going to be a big changer, a lifeline for HIV. But they were very expensive. I remember triple therapy in that time was anywhere between $30,000 to $50,000 costs a year. So it was completely outside our reach. But it was very effective from the clinical trials. So the struggle between 1996 and I would say the other landmark, from 1996 we had another AIDS conference. So we have this big AIDS conference every 2 years. But I remember the one in KwaZulu Natal, in Durban. It came to Africa, where huge activists demanded these drugs to come down, the cost to come down in Africa, because that meeting was held in Africa, and Africa had the highest burden of this disease. There was a lot of activism, a state of pressure on drug companies to provide cheaper drugs for this disease. And prices started to tumble a bit, but I think the biggest changer for provision of ARV at scale, underline the word at scale, Mr. Musinguzi, was when PEP FAR came in. PEP FAR. And believe it or not, I had the privilege to go to Washington when Bush Senior, Bush Jr., President Bush was pushing the PEP FAR program through the House of Representatives. It had passed to give a huge AIDS package to 10 African countries. But that, you see, whenever expenditures in the United States have to be approved by the House and the Senate. So this bill was now moving over to the Senate for its approval. So a group of us went to talk to senators to approve this proposal and why it is so important. And I remember talking to several staff of senators why we should do this. And that was a very big, bold move by President Bush in 2004, I believe. I could have the year a little bit off. But when it was approved, Bush was going for a G7 meeting. So he wanted to go with this approval at hand and ask other governments in the G7 to also make their contribution. But that made a lot of resources available. And when it did that, it created economies of scale. You know, if you can afford to buy $1 billion of drugs, you always get it at a cheaper price. That really changed the dynamics of HIV in Africa. No question about it. Drugs became available. We started giving out drugs in Rakai in 2004. And everybody who needed it got it. And I think that really was a huge, huge game changer. Really did. That is now the story of the drugs. 1996 in Vancouver. That's when we really said, oh, these drugs could really make a big change. So the first change was in the availability of those drugs, the effectiveness of those drugs in treating HIV positive people. Now the question was now to reduce the prices, as outlined. But the other landmark was trying to get studies to show that actually drugs can equally be effective in preventing people acquiring HIV. i.e., you are HIV negative, you take these drugs, and then what we call PrEP now, and then you can reduce your chances of acquisition of HIV. That was also another big game changer. And the drugs were initially expensive also, but now they are really coming down. It's a combination of treatment to reduce transmission and also the medication to reduce acquisition is where we are now.
Uganda is one of the success stories of when you talk about HIV/AIDS in Africa and across the world. Uganda is mentioned among the successful studies. How did we get this right, and when did Uganda start getting things right?
Success story, I like to look at it in periods, times. I think Uganda, from 1986 when President Museveni came on in power, it changed the dynamics. So leadership was extremely very critical. Museveni was very open to realize that HIV was a big problem to Uganda and it had to be tackled. We needed to educate people so he could talk about AIDS to increase awareness. So once the leadership accepts and we can talk about AIDS, therefore everybody downstream can talk about AIDS. It creates an environment where we can do prevention, we can do research. So I would say from 1986, Mr. Msinguzi, when President Museveni came on, Museveni was unique in his ability, of all leaders in the region, to openly talk about AIDS and educate the population about AIDS. And it gave us a huge, donors were very interested because we could operate in this environment where there's easy acceptability of this problem. And so whether you are in prevention, healthcare, whether you are in research, it created a very good environment for us to work. So care at that time was health education to prevent, zero grazing, and also to make sure that you reduce your sexual partners, condom promotion, and so forth. We in research, we were free to be able to conduct all kinds of research that could enable us to understand the dynamics of HIV transmission, be able to know who, where, and people are infected, and be able also to see whether the possible intervention. So it was a very good environment. That went on into the 80s and then in the 90s, and so it created a so because of that environment, Uganda was very much involved in so many innovative researches and program initiatives. I can tell you a few. For example, Uganda was one of the first countries to set up HIV testing centers where people can go and be tested for HIV. Now that seems very easy thing to say, but it wasn't easy at the time. You know, people said, "Oh, you're going to make these centers available. People are going to test themselves. They find they're positive. They're going to commit suicide. They're going to do this." So there were a lot of people there was a lot of pushback, but we said, "Okay, let's try it and see what happens." Well, people weren't killing themselves when they learned, but actually some people took it as an opportunity to do prevention. So that HIV testing center was very important. We did some of the seminal studies on HIV prevention. Moju did prevention of mother-to-childhood trials. In Rakai, we did circumcision trials, and the first HIV vaccine trials were actually done in Uganda, in Africa. So the context of trying to figure out, what works, what doesn't work, was very much, and that put Uganda both in the scientific and also, programs like TASO were key studies for the rest of the countries on how to take care of people in home-based care. And so there are quite a number of examples to show that we had a lot of leadership, initiative. But that was mainly because of the environment that the president put up moving forward.
And globally, when you look at the research and innovations of the past 40 years, if someone asks you what has been Uganda's contribution to this research and innovations in understanding HIV/AIDS,
it's been significant. We have been on the table of doing quite a number of trials. I told you Uganda did the first vaccine trials. Uganda was involved in many studies that were looking at that first demonstrated that viral load is related to heterosexual transmission. That means the higher you have viral load, the more likely you are to transmit. That means if we started treatment and reduced your viral load, we will reduce transmission. And that's what informed WHO to test and treat, not to wait for CD4s to go down until we start to treat. Circumcision trials, acquisition, that's circumcising adult men reduces acquisition. Those were trials done in Uganda. WHO and UNAIDS adopted those as a method of prevention of HIV acquisitions. So you can see quite a number of studies that we've done that have translated into policy, and eventually, if implemented to scale, have had impact on HIV transmission dynamics.
Back to 80s, 90s, and the 2000s. I'm trying to get the demographic characteristics of this disease and how it changed over time. You had earlier told us that it was affecting some people who relatively had some money. Was it majorly men? Was it majorly women? Was it majorly kids? How has that changed over time?
That's a very good question, Mr. Msenguzi. What we found was the sex ratio of men to female in the early phase of the epidemics was 1-to-1. There was one male to one female. However, it was the age. You'd find that older men were infecting younger people. So you had, younger women. So you had a higher peak of HIV prevalence in young women, and the peak for men was a bit later. So you'd have a peak of HIV prevalence in men at around 30, while in women it was around 20 to 22. So the age difference is that men were actually infecting young people. And over the years, what we have found now, that actually the age at which women peak are now shifted to much later years, towards the 30s. And for men, also the peak age of HIV infection has also shifted towards the much older age groups. And you find that for every 3 women who are infected, 1 man is infected. You see? So a much higher burden of HIV infections still in women. But it means that fewer men are transmitting infections to a higher number of women. So there has been a change over time. And that dynamics is largely played by a number of factors: availability of treatment, universal primary education has shifted young women, delayed age of sex, but also sexual activities in young women has really decreased. And I think those are the 2 major drivers. Universal health education has really been more impactful in HIV, as far as HIV, particularly towards women. There are more women in schools and therefore less likely to get acquisition of HIV.
In terms of Uganda's national rates, when did we achieve a significant reduction in terms of the rates?
A significant reduction in Uganda of HIV incidence started from 2004. If the curves are very clear. 2004 is when we started to initiate treatment. Then the subsequent years, HIV incidence has been going down up to now. Let me give you a typical example for Rakai. Before we started, HIV, to be sure, was going down even before 2000. Mainly prompted by a lot of health education, health promotion, and so forth. But then in 2004, we started initiating treatment. And initially we started when people had a certain number of CD4. In Rakai it was around 200. HIV started incidence, that is the number of new cases we are seeing every year, started to go down. And you see a steeper drop when we started to test and treat anybody. Okay, so we moved from 1.2% of HIV incidence, we are now at 0.07. Significant drop. We are below 1 now. And that picture is seen in many of our national surveys, the FAR surveys that we do in Uganda. So, every 5 years, the same picture of HIV going down. But it's mainly driven by treatment.
It coincided with PEP FAR.
PEP FAR. PEP FAR was a game changer.
Since that time, a lot of drugs have been developed, and of recent we have the Kaposi,
right,
which is an exciting drug. What does it mean for Uganda?
I would like to tell you that some of these studies, PrEP, the first PrEP study, the partner study was actually done in Uganda, which tested whether people who are HIV negative but are in discordant relationship can reduce their acquisition. This was done in Tasso. And then the subsequent studies on long-acting injections using cabotegravir, which came on before lenacapavir, were all done in Uganda. And so Uganda participated in all these studies that generated the data to show that PrEP can be very effective. So PrEP, Musinguzi, you should think about trying to control HIV as being able to have, it's a cocktail of strategies. So PrEP gives us another weapon in the mix of trying to reduce HIV. So we've told you that, or we have discussed that HIV treatment reduced transmission by reducing viral load in HIV positive people. But we also need to look at HIV negative. The nature, especially the vulnerable HIV negative. How can we also reduce the rate at which they are acquiring? So lenacapavir or all PrEP agents give us that opportunity to prevent. But what was so significant about lenacapavir or cabotegravir is that we realized that PrEP taken as tablets, in order PrEP to work, you need a very high compliance of taking your tablets. That was seen as a very key component. Very effective, but you had to take your medication. And if you didn't, it wasn't as effective. So these injectable try to eliminate compliance. So lenacapavir 2 injections in a year. Once you give it, that's it. So compliance doesn't become a very big factor.
There is no taking tablets at home and forgetting it.
Forget them. That means it will increase its efficacy. And no, not necessarily increase its efficacy. It will improve its overall effectiveness is the word, in terms of preventing acquisition. So having both those armaments in our fight, I think, is going to be very important.
Aren't you worried, because many people are excited about it, aren't you worried that it can increase promiscuity again?
People say that. I mean, am I worried that if you have HIV positive and then I treat you and then you have zero viral load, it will increase your promiscuity? Why aren't people talking about that? You know, that in itself, we have seen that this was the same issue with circumcision. Or people who are circumcised, they would think they are protected, and therefore they haven't seen, that has not been borne out by our studies. And I do not think that that is speculation, but not, we call it disinhibition. People trying to behave because they think they are protected. It's a bit like, oh, because I have a seat belt on, I can afford to be a bit reckless, because if I get into an accident, I have a seat belt on, and therefore I'll not have bad injuries. But the evidence, to be honest, there have been some evidence in America that showed that there was some disinhibition behavior among people who were on treatment, but we have not seen that in the studies done here.
The very last question from me. After more than 40 years of studying this disease and understanding it and looking at where we have come from and where we are going, what should the next generations never forget about this disease and where we have come from?
Very good question. The next generation should be aware that if we relax our efforts to prevent HIV, starting from you as an individual, specifically your sexual behavior, number of partners, condom use, to our country programs, HIV infection will come back. We have seen this in other diseases. Malaria. Prevention control measures for malaria started to get relaxed as we were starting to control malaria. Resistance came up. Resistance can come up with these drugs on HIV. And malaria
When I was in medical school, we thought by now we would not be talking about malaria. But malaria is still here. HIV is not gone. HIV can come back and actually kill as many people if we are not as vigorous to protect the gains that we have had, and also to make sure that the younger generation actually does not forget that HIV is present, and they should behave as if it is still there.
Thank you, Professor.
Thank you very much.
It has been a pleasure talking to you and learning from you.
Thank you very much, Musinguzi, for having me.